Thank you. Pleasure to be here. I want to thank the MMRF, the sponsors, and of course all of you for showing up. So many of you hear about the cancer journey, so I'm going to actually help you with the journey during my talk. For any of you who heard me talk a few years ago, I like to show pictures to kind of lighten things up because it's such a heavy topic. So we're going to go on a little tour of a variety of places while I'm doing my presentation. So it really is a pleasure to talk about stem cell transplant. You really are fortunate to have the faculty we have here today. These guys, I'm not speaking for myself, these guys are really good. And Sagar's been in all the oncology news lately about, I'm sure he's going to talk about it later, this monoclonal antibody, which hopefully is going to come to FDA approval by first quarter of next year. We'll probably have 2 drugs available the first quarter of next year. Before we start, even though you're going to take a break in a few minutes, I'd like to get you a 2-second exercise bit. Anyone who's had a transplant, please stand up. Stretch your legs. Yeah. You guys are the ones who are going to stay mobile for a longer period of time, right? Okay, you guys can sit down after you stretch a little bit. Those who've not had a transplant, please stand up. Oh my God, you're missing something good here, guys. All right, so is this working? All right, so modern myeloma, at least the determination of modern myeloma, actually started not with Winston Churchill and myself here outside of by Big Ben, but the actual first case of multiple myeloma was described in 1844 in a lady by the name of Sarah Newberry. I show this to show some of the treatments we've had because we're going to build up to transplant. So the first treatments, as you can see on this slide, were that they gave orange infusions and rhubarb, which may have been great if you were on an all fruit diet, but it probably didn't do a hell of a lot for myeloma. The first maintenance therapy, we're just going to talk about maintenance therapy, and as you'll probably hear either now or when we have our panel discussion, I'm going to give the data on maintenance therapy. I'm not a big advocate of it, but the first maintenance therapy was actually being sucked by leeches. They did this is a real thing. They would bleed people, and they would bleed them using leeches, and this was in 1845. It wasn't until 1947 that we actually had a therapy that they thought worked for myeloma, and we're going to talk about this a little bit later because no one else has shown the slides that I have actually borrowed from one of our other colleagues. But it wasn't until 1962, as you just elegantly heard, that melphalan, which at that time was an oral agent and now we use for intravenously for transplant. For all of you who had transplants, you got the IV form of melphalan. Some of you, probably not very many, have had oral melphalan, but it was discovered in 1962. And this was the standard of care, and it remains the standard of care in Europe in many centers because it's very, very inexpensive. And we are blessed to live in the United States where we do not have socialized medicine like they do because there's a whole variety of medications that we have access to here that they don't have access to in Europe because they won't pay for it. So, and that includes transplant. And just so you know, when I show you this particular trial, transplant trial was done in Europe. In Europe, if you're over the age of 65, unless you're part of a clinical trial, you cannot have a transplant. They just don't pay for it. If you have private insurance, sort of like here, you could have a supplement for Medicare or something like that. In Europe, you can have private insurance and may get it covered. But outside of a clinical trial, most European countries will not transplant patients over the age of 65, whereas Medicare, to our benefit, will have no upper age limit for transplantation. This trial was the first trial. This is actually a very old trial. It was published in 1996. And in this trial, they compared conventional therapies, which we don't even use anymore, compared that with transplant. And you'll probably see more of these slides between either myself and my colleagues. But when you look at these slides where they've got 2 lines or more than 2 lines, the line on the top is the group that did better. So in this particular case, that greenish colored line is the group that did better. That's the group that got the transplant. That reddish orange color was the group that did not have transplant. So since 1996, when this randomized clinical trial came out, transplant's been considered a standard treatment for this disease. So that's kind of old history. And just so you know, this is Petra. I'm not going to torture. Sometimes if I have a lot of time, I torture people in the audiences, and some people are really good. This is Petra. Now, I want to point out, though, about Petra, this is not a building. This is a carving. If you look at this thing, this is a mountainside, and they actually carved this building into the mountain. This was not built, it was carved. And that's what that whole civilization was about 1,800 years ago, whatever it was, when Petra was at the peak of the, I think they call it the Silk Trail or something like that, where the caravans used to go through there from the Far East to get to the Middle East, and they used to go through Petra. So you've already seen a slide similar to this, and some of these slides are reproduced, but that's good because the more times you see things, you can actually absorb them better. So you saw this slide in a different format showing all the different drugs we've had over time. And I'm not going to belabor that issue. And you've also seen a slide something like this. So when a patient comes in to see me or my colleagues, we have to decide if they're transplant candidates. And the definition of who is and who is not a transplant candidate really varies among the myeloma doctors. And there's kind of two camps. There's a camp that thinks that everybody should be transplanted. There's a camp that thinks that maybe select people should be transplanted or they should be transplanted later. I'm not going to really get into all those controversies, but not all the myeloma experts believe in transplant, believe it or not. That being said, if you come to my center, we essentially transplant everybody that walks in the door. I'm not trying to be facetious, but that because we believe very strongly in this therapy. Other centers, the likelihood of being sent for transplant is lower. So you have to decide if they're a transplant candidate, and based on whether they're a transplant candidate or not, you may just decide what kind of drug regimen you use. You've just heard about all these combinations of drugs. In general, and it's not an absolute, in general, for patients who are being considered for transplant, we usually give them a 3-drug regimen to prepare them for a transplant. If you're not a transplant candidate, most of the docs will probably only give you 2 drugs, thinking they'll save the other drugs for later. So in transplant, we try to get a deeper drop in response before we do the transplant. If you're not a transplant candidate, we often only use 2 drugs. So this slide is a little bit different, but we do use slightly different approaches to patients who are transplant or non-transplant patient candidates. Why do we do transplants? Because this idea that more is better works. We give a high dose of this drug called melphalan. Melphalan kills more myeloma than any single drug that anybody can tell you exists. Now, I'm not saying that you have to have that, and some of my colleagues may or may not agree, but melphalan is definitely the most potent single drug at high doses than anything else we have in our armamentarium to treat this disease. That being said, there's questions that need to be decided. So because there's so many good drugs, and you're going to hear about more good drugs coming available very soon, one of them is this monoclonal antibody that Sagar's the lead investigator worldwide on. Where does this all fit? If you got all these great drugs, you really need a transplant. We're going to talk a little bit about that. Which patients are the ones who are most likely to benefit? Which are the patients who are least likely to benefit from a transplant? When should you do the transplant? Should you do it right away? Should you wait till later? Yep, these are all things that have to be determined. And then there's this issue of maintenance therapy to try to keep the disease asleep for a longer period of time. So this is, if you're true transplanters, this is what happens when I'm on call. So there's different kinds of transplants. The most common type of transplant that's performed for all diseases in the world is for multiple myeloma. In the US, there are about 25,000 transplants performed for all diseases, and myeloma is about 5,000 or 6,000 of those. It's the most commonly transplanted disease around. And this is not true just in the US, it's outside the US. And the most common type of transplant is using your own cells, which we call autologous. There are different places you can get cells. You can get them from your peripheral blood. You can get them from the bone marrow. We almost never use bone marrow anymore except for select sites who do donor transplants. Or you could do a donor transplant. For a donor transplant, which has a term called allogeneic transplant, you can use a sibling, you can use an unrelated person, or you can use an umbilical cord. So these are just where you get the cells to do the transplant from. So again, the whole concept of doing a transplant is higher drug doses kill more cancer. And we've also shown, and which AJ just talked to you about the response rates, which are it's kind of a mish of nomenclature for you to try to understand, because I'm going to show you a couple different slides on responses. So the whole idea is we want to get rid of as much cancer as you can. And that's what's shown in this slide. Again, the top line is the group that did the best. Those are the patients that went into complete remission. We couldn't detect that they had myeloma by routine testing. And when you look and see how long they live on this slide, they live for 6 years or more on average. So the more cancer we kill, the better you do. And this slide, which doesn't project well, actually divides these different response rates even further. So there's different terms, which I'm going to show you, and it was just mentioned to you before. There's this thing called minimal residual disease, and I actually stole one of Sagar's slides, which he's probably going to show. But there's different levels of getting rid of cancer, and we have different names for those different levels. In this particular slide, which you should have in your handout, there's one that says SCR, which stands for stringent CR, or I kind of call it super CR. It's like getting 105 points on a 100-point test. And if you get a super CR, which again, this top curve on these curves, you do even better than you just get a CR. So if you get 105, you get better than you get 100. And it's better than near CR, which is 99. So it just shows that different levels do translate into improved remission durations, and some people believe into overall survival. And this is actually Sagar's slide. No offense, Sagar, thank you. I can't imagine he's not going to show this. This is classical. Everyone that's ever heard Sagar speak steals his slide, I think. And what this is supposed to show is that there's different levels of disease. Here's a complete remission. This is the super remission, stringent CR. And we're going to talk, and it was mentioned just briefly, about these minimal residual disease. And ideally, we get down and wipe out the iceberg completely, and we get cures for this disease. So this is, again, I'm not going to torture anyone. This is in Barcelona. For anyone who's been in Barcelona or Spain, one of the premier architects in the late 1800s, early 1900s, a guy named Gaudi. And Gaudi designed this park. It's sitting up on a hillside in Barcelona, overlooks the city. And it's unbelievable, this guy. If you've ever seen pictures or anything of Barcelona, there's this church called the Sagrada Familia, which is a church that they've been working on for 100 years. Still haven't completed it, that he designed over 100 years ago. They're still trying to complete this church. It's an unbelievable church. Anyway, in Spain, they came up with this new technique to try to come up with even a better definition than the super complete remission. It's like supercalifragilisticexpialidocious. So we have a super test to find out if you've gotten rid of myeloma. We call it minimal residual disease. And there's a couple different technologies to do it. The one that's becoming most prominent is this thing called flow cytometry. It's done on your bone marrow. No offense to anyone here. This is how you figure if you've got this level of response. And again, the top line shows that if you get this super remission, you do better, you stay in remission longer, and you live longer. So getting rid of more is better. Again, getting back to the theme that transplant, the melphalan, is the most likely drug to get rid of the most disease. So we do this. It's a standard therapy. Do you have to have one? No. There's other therapies that are good. There's no upper age limit. We routinely transplant people that are relatively fit up to age 80 in our clinic, in our program. The mortality rate, the chance of dying from a complication, is really quite low. In the under age of 70, the chance of dying from a complication is 1 in 250 patients. 1 in 250 patients chance of dying from this. It takes 14 days, and I've already tried to impress upon you that it's the most potent treatment. You don't have to have a donor. It's covered by all the private carriers. It's covered by Medicare. It's good treatment. This is the basic process for the half of you who've had a transplant. You get initial cycles of therapy. You get your stem cells collected. We have a mobilization. We have to collect them, and we collect them out of your bloodstream. There are small numbers of bone marrow cells. The bone marrow and the bloodstream are a two-way street. It's not a one-way street. Cells go in, cells go out, and we can collect bone marrow cells or increase the number of bone marrow cells in your bloodstream and collect them on a machine. And then we can freeze them away. We can use them when we want. And for those who somebody's bound to ask me, the cells are good for all practical purposes forever once we have frozen them. So sometimes we don't know what to do, how to figure out what's the best way to get the stem cells. So some of us get together and we have a group meeting. And ultimately, we decide on every individual patient what's the best way to get their stem cells, but there are actually different ways to collect these stem cells. The majority of centers, everyone uses these shots called Neupogen, or there's some centers may use Neulasta, which is like super long-acting Neupogen. Everyone uses growth factors, and some centers use chemotherapy and growth factors to collect the cells. The bottom line is we just want to get the cells. Depending on your previous treatment, may help determine what way we want to get the cells. Now, the treatment that we give to collect the cells, if you get chemotherapy, that chemotherapy really doesn't help much for the myeloma, but it really is a good way to get the cells out of your bone marrow and into your bloodstream. So one of the typical questions patients ask me, well, you clean up the cells after you collect them, and the answer is no, we don't. We have tried this. This is actually very old data. Back 15 years ago, we had a couple different technologies to clean up stem cells. We would take the stuff we collected on the machine, we'd process it with different technologies, and we'd see what would happen. And what we found out that you can process the cells, you can get rid of 99.9999% of myeloma cells out of the product, and the patients had the same relapse rate. And not only that, but they relapse at the same rate, and when you purify the stem cells to that degree, they actually had longer time till their cells grew back when you went through your transplant, and your immune systems were compromised for a much longer period of time. No one is doing stem cell purging or purification at this point in time till we have new technologies. So the French decided to do a study based on Arkansas data. And for any of you from gone to Arkansas, seen BART? For those who may or may not know, BART is moving on out of Arkansas, I think in August. Word on the street, not that I should be a rumor monger, is he's landing in Mount Sinai in New York, is the latest, but he's definitely leaving Arkansas for those of you who have either heard of him or been taking care of him. But Arkansas pioneered doing double transplants. I was in Arkansas for 6 years in the early 1990s. I participated in a trial sequence called Total Therapy. Ultimately, though, there was a question if you should have 2 transplants or 1 transplant. In the French, they decided to do a study of 1 versus 2, and they found that some patients who had not achieved a good response were the ones that would benefit from getting 2 transplants. So in their study, this is a study that was designed in 1994. 1994, they decided that 2 transplants should only be done in select individuals. Again, if you go to the Arkansas route, they think that if 1 transplant works, then 2 transplants are going to work better. So, but this trial was a randomized trial, 1 versus 2, and 2 did beat 1, but only in a subpopulation of patients. Well, that's kind of old history. And the US decided to repeat the trial, because again, that was a 1994 trial. So the US repeated this trial. The results are not going to be available for another year and a half. But they decided to look at 2 transplants versus 1 transplant, or 1 transplant with consolidation, giving something after the transplant but not a transplant, which is this RVD or VRD, which is Velcade, Revlimid, dexamethasone, and all the patients on this trial got Revlimid for maintenance therapy. So this is a 750 patient trial. The French trial I alluded to was 400 patients. This is a 750 patient trial. It's a much stronger statistical trial, but we don't have the results for another year and a half. You've already seen this slide. We have great therapies. We are blessed that we have great therapies and new therapies coming down the road. These therapies, when you look at these bars, just to explain them, when you look at the overall response rate, all these therapies, this is 100%, all these therapies get essentially almost 100% response rate. This is a little bit generous because they're not quite 100. And the depth of response, this VGPR, very good partial remission, has increased depending on which alphabet soup of drugs you've got. So we have very, very good treatments. Well, the Italians, sorry, this is my cousin David. I'm a little more modest. I decided to wear clothes today. The Italians actually did a trial that has some faults to it, but they did a trial to answer a more modern approach. I showed you in one of my earlier slides that the French did a trial showing that old therapies were not as good as transplant. So the Italians decided to do a trial of looking at newer therapies versus transplant. So they did a trial of Revlimid dexamethasone, and half the patients got melphalan-prednisone. We talked about oral melphalan, which no one in this country would ever do this trial. Melphalan-prednisone Revlimid, or they had 2 transplants. So they're looking at a Revlimid-based transplant, a Revlimid-based therapy versus a transplant, because Revlimid's a new therapy. And what they found, this is very simple to look at, when you look at the group that had the transplant, the likelihood of being in remission was almost twice as long if you had the transplants. The likelihood of being alive at 4 years was significantly better if you had the transplants. So one of the faults with this trial, which one of my colleagues probably would jump up and scream, but they never got Velcade in this trial. So they didn't get a Velcade Revlimid in the non-transplant arm, they only got Revlimid. And that really is a problem, plus there's some statistical issues with this trial. But if you look at it at face value, even using modern therapies, transplant was better. So this is time for a commercial. We're going to have a commercial here, and this is a great place. This is the ultimate place to show this commercial, in that Coca-Cola is based here in Atlanta. And one of my colleagues has this slide. I apologize, but I'm up first. So this is a very, very important slide. It is to teach you a couple things, and not that you should go out and buy your Coke, or like I do, I live on this stuff. But this is a trial. If you remember, I told you we talked about rhubarb and leeches. Well, one of those drugs from 1947 they thought had myeloma therapy was urethane. So urethane is in floor hardeners, it's in plastics, and you can purify it so you can give it to people. So in the 1940s and 50s, they thought urethane was myeloma therapy. Well, the scientists, the researchers decided, well, let's test it. Let's find out if urethane really works. So they did urethane versus Coke syrup being the placebo, okay? This is a real trial. It was published in one of the high-end journals called Blood. This is a real trial. This really happened. 83 people volunteered to be randomized to either urethane or Coke syrup. What they found, what they found, again, the line on top is the group that did better, and it's really kind of hard to see this, but the line on top is the Coke syrup. Okay? So this is important. The reason I bring this in here, because I think Ravi's going to talk about relapse disease, and Sagar's going to talk about clinical trials. I got news for you. People like you didn't participate in clinical trials. You all be getting urethane. Okay? So when next time one of you says, well, I don't know if I want to be a guinea pig, I don't want to be a clinical trial, it sounds scary, think of urethane. Okay? And tell me that you want to still get urethane when we've got something better on the shelf. Enough of the commercial. There is one of the current main issues internationally is not should you have a transplant, but when you should have a transplant. So this is an international trial. It was done in France. The French have finished their trial. They're probably going to show their results at ASH, which is probably going to destroy the US part of the trial. But it was a French-US trial of 700 patients in each continent. So in this trial, they were asking a question, is when to do a transplant. And the group on the left gets 3 cycles of Revlimid Velcade Dex, they get their stem cells collected, and then they get a transplant. They then get consolidation, they get more RVD, and then they go on maintenance therapy. So this is the early transplant group on the left. The group on the right gets their initial therapy, they get their stem cells collected. Everyone gets their stem cells collected. Then they get 5 cycles of RVD, consolidation, and then they go on Revlimid. And this group gets transplanted when they relapse. So it's an early transplant versus late transplant. I think, based on what Philippe Moreau told me, they're going to show this data, at least the French part, at our national meetings in December. And we may have an answer which is better, early versus late. So we now know that upfront transplant right now is still the standard of care. The experimental arm on that trial I just showed you is the group that gets the late transplant. The standard of care is to get the early transplant. So do we need another trial to compare transplant versus non-transplant using all of the modern classes of drugs? The proteasome inhibitors, Velcade or carfilzomib, the immunomodulatory drugs, Revlimid or pomalidomide. Do we need to really do another trial like the Italians did to compare transplant versus no transplant and see who wins? What about patients who get a complete remission? Do you still need a transplant if it's all gone, or if you get this super remission, do we need to do a transplant? I don't know the answer to that because no one knows the answer to that. So we really want to try to get to that level of, of treatment. So we don't want things to die out. This is Machu Picchu. It doesn't exist. The area exists. The whole people died out. Whether it was due to the Spaniards and their syphilis and all the like, I don't know, but they don't exist anymore. So we don't want your response to die out. We want to keep it going. We want you to stay in remission. So if you use that philosophy, then one way of staying in remission longer is to suppress the myeloma, keep it asleep, and give them maintenance therapy. Why should we do this? We want to keep you in remission longer. Hopefully, we'll make the response better if you go on something after, even if you have a transplant. And we want you to live longer. All of these are great goals. Do we achieve any of these goals? Well, the first treatment was thalidomide. Long story short, because I'm running late, thalidomide actually works. It improves remission duration. It improves survival in some of the studies. Unfortunately, thalidomide has a lot of side effects. And in the US particularly, the US did a large trial about 6-7 years ago, and only 20% of the people in the US would take the thalidomide compared to like 80% in Europe. So in the US, they really can't tolerate the thalidomide. I don't know if it's a genetic thing or what, but it has side effects. So we moved on to Revlimid or lenalidomide. There are actually now 4 trials, I'm only showing you 3 on this slide, showing if you go on Revlimid after you've had initial therapy, you have about a 20-month longer remission duration, 20 months. So just for example, if you get 30 months, if you have a transplant and the average time to stay in remission is 36 months, that's throwing a number out. If you go on Revlimid after transplant, then it would be 56 months. Everyone with me with the math? So that's what this showed. Now, what's debatable is whether any of those patients live longer. One of the trials says yes, the other trial says no. Actually, 2 of the trials say no. But there is no doubt you stay in remission an extra 15 to 20 months longer if you go on Revlimid maintenance. Well, to be fair, what about Velcade or bortezomib? Well, the Nordic group, the Hovan group, Hovan and German group, actually did a trial with Velcade. Well, Velcade, you have to come in for your shots, unlike Revlimid, which is a pill. And it's kind of a pain in the stomach, if you will. But they did a trial, and they actually showed that patients who got Velcade before their transplant and Velcade after the transplant had a better remission compared to thalidomide. So Velcade looks like it works. This is a smaller study, but it does look like it works as well. But it's very, very inconvenient. So thus leads to, I'm sure one of my colleagues is going to talk about Exasumib. Exasumib, I don't know if do we have the trial here? Do you do any? Yeah. So I don't know if anybody here has been on Exasumib. Exasumib is essentially, no offense to Takeda, but it's essentially oral Velcade. So instead of getting your shots, you just take a pill and you take it once a week. So this is a trial that was just recently shown at our meetings in December, where they took regular therapy, they gave them Exasumib, or the equivalent of Velcade, Revdex, and after that they put them on Exasumib maintenance. What they found is that they had great remission durations, and they actually had a 50% improvement in how good their response was with Exasumib. So Velcade's really not a very good agent, it's not convenient. Exasumib is a much better agent to consider for maintenance therapy. So in summary for maintenance therapy, PFS is how long you stay in remission, OS is how long you live. There's no doubt you stay in remission longer. I completely agree. It's debatable to me, in my mind, whether you actually have a survival advantage. There are toxicities of treatment. First of all, you're taking pills, 21 days out of 28. They can cause low blood pressure, they may cause some diarrhea, they may cause some fatigue. There are side effects to taking a maintenance therapy, side effects to any drug. We don't know if you're in a great remission, if you really need it. The French trial, I should say the US trial, seems to indicate that everyone benefits, but you may not benefit as much. We don't know how long to put patients on maintenance. The French say 1 year, the US says it forever. And the issue, one of the main issues I have besides cost, because we're talking 100 grand a year if you go on Revlimid maintenance, is that if you're on a low dose of Revlimid, what happens when you need Revlimid when the disease gets worse? And we don't know if you can use it again because you may have blown that opportunity using a low dose of the drug. So unlike Darwin, this is in the Galapagos Island, um, where evolution, he documented that evolution, these are land tortoises, our blue-footed friends as well as iguanas. There are other options. I only going to touch on this very briefly. There's members of my esteemed colleagues who don't like allogeneic transplant at all. But this is donor transplant. Donor transplant has two potential advantages. One is you don't have to worry about stem cells having myeloma in them, and donor immune cells can kill sleeping myeloma. There is no doubt that the donor immune system can kill any myeloma that's left. Those all sound like great ideas. But I already told you the risk of doing a transplant using your own cells approaches 0. The risk of doing a donor transplant approaches 20%. So it's a high-risk procedure to try to achieve a true complete remission, to cure people. We can do this from brothers, sisters that may match. We can do this from unrelated people. Rare do we do umbilical cords. The current craze in the transplant world is using half matches. My two little sisters here from Japan. In China, where the government limits everyone to only one child, they are doing half-matched transplants from mother to child or father to child. They're doing them like right and left. So you can actually do a half match. So almost everybody can find a donor because almost everyone still has either a parent or they have children. Yes, there are some exceptions to that rule, but almost everyone will have a half match available to them. It's still in the investigative phases, but it certainly can be done. But half match, full match, wherever you get the cells, the risk is about 20%. There was a very large trial done in the US. There was also a large trial in Europe. They came up with different conclusions. The US trial showed that donor transplant wasn't any better than doing auto transplants. In contrast, the Europeans said that doing a donor transplant was better than doing a transplant using your own cells. Currently, there's a national trial looking at the high-risk patients. Both previous speakers talked about the high-risk group. There is an interest to try to fix these high-risk patients by doing donor transplants. This is a national trial. First patient hasn't even been enrolled yet, but it's going to be a 138 patient trial to look at whether we can fix patients with bad myeloma. And this particular group of patients actually is going to go on Ixazomib versus a placebo for maintenance after they have their transplant. So these are things that you need to ask your doctor. Are you a candidate for transplant? Are you not a candidate for transplant? When you should do your transplant, if you should have one, should you do it early, should you do it late? Are they familiar with doing transplants? Essentially everybody who does transplants are familiar with doing myeloma. Almost any center can do myeloma transplants. They are, for no offense to the people here who may have had a tough time, but compared to other diseases, myeloma is really the easiest disease to transplant because it's such a anticipated side effect profile that happens during the transplant. Any transplant center is very familiar with doing this. The transplant takes about 2 weeks. We do some of our patients as outpatients. They come back and forth every day. You don't necessarily have to be in the hospital. For those of you who are Medicare thinking about having a transplant, Medicare won't pay for outpatient. You have to be in the hospital if you have Medicare. The response rate, over 95% response rate in the upfront setting will respond to transplants. And in general, 4 weeks after the transplant, you should be feeling probably as good as you did going into the transplant for the general patient. And with that, I'll end. Do we have any questions?
You used a survival curve that went out 7 years. Thank you. You used a survival curve that went out 7 years in some of your earlier slides. Was that because some of the new drugs, we don't have data going out further, or was that when the
Yeah, so the survival
stopped?
curves are really hard to pinpoint, not the remission durations. Those, we've got a really good idea of how long people do. You know, as Jeff, I think, passed over very quickly when he talked about the staging, at the bottom of that slide, they had numbers which I don't like. And I actually took them out of that slide about how long people live. But for people with standard risk myeloma, which is probably 75% of you, the survival is 10 years plus, and not counting the drugs that are coming available. Transplant gives you, a couple year longer remission. in our experience, we don't use maintenance because somebody will probably ask me, or it may come up. I don't use maintenance, and it gives patients actually 3 years, probably on average, freedom of all drugs, which most people really like, not to be taking drugs. Pardon? It's 30, about 30 months would probably be the average. And 30, it's 30 in the US trial, I think.
Yep, my question was on the benefits of the second transplant, and that was referring to a tandem.
Yeah, so the benefits that they saw, again, this is very old data, and I really don't like to talk too long about it, but the benefits were only in patients who did not get a VGPR. VGPR means a 90% reduction in their myeloma number. So if you started at 5 and you got under 0.5, that was the group that did not benefit from having a second or a tandem transplant. But if you went from 5 and it went down to 1.5, that's not 90%. That was the group of patients who did benefit. The likelihood of being in remission and alive was double in the patients who had the tandem transplant in that French study.
And a second transplant is not an option after relapse.
It absolutely is an app. I should include relapse transplants sometimes. We call them salvage transplants.
Right.
Absolutely. We collect enough cells. All the transplant centers collect enough cells for 2 transplants or more. The cells are good forever. A rule of thumb is that if, let's say you had 6 years from a transplant, the first one, and then you relapsed and you got something to get you back in remission, and you said, well, I'm 58 years old, I want to do another transplant. The rule of thumb is you get about 40% of the time out of the first one. So if you got 6 years out of the first one, you're going to get about 2.5 years out of a second one, but that's still 2.5 years without treatment. If you look at the national studies, if you look at across the board, everybody gets a second transplant. It's actually not that promising, but that's ranging from 6 months to 10 years, and the number is much lower. In general, it's about 40% likelihood that you stay. The remission duration is about 40%.
Revlimid has a tendency to lower the neutrophil count, or it does for me, and I'm using it as a maintenance drug. Now, are there if it gets to the point where I can't use Revlimid, would there be something else as a maintenance drug? And like you said before, if you need Revlimid again, what's going to happen?
Yeah, I don't know what's going to happen if you progress on Revlimid maintenance. There's really not a lot of data. There's a study being conducted in the New York area to look at that. The issue of low blood counts in the French trial, and Sagar may know the data on the US trial. The French trial, 15% of the patients had to come off because of low blood counts, even when they had dose reductions. But Revlimid comes in a whole variety of doses down to 2.5 milligrams.
I'm down to 5.
And most people can tolerate it 2.5 milligrams every other day. If they can't even tolerate that, they've really got issues and they'd have to come off. There is no other alternative right now that's been proven. The Ixazomib or Velcade may work, but it has not been looked at in nearly the extent of the clinical trials I mentioned with the Revlimid. So we don't know that yet. But those can also cause not so much low problems with your neutrophils, but cause problems with your platelets. So there's always a trade-off.